Hello everyone, welcome back once again to the respiratory system pharmacology. In the previous lecture, we handled asthma or bronchial asthma. Today, we are going to handle another condition that affects the respiratory system, and that is the chronic obstructive pulmonary disease. The person presenting to you is by name Grace Young. I am founder of grapharmacademy. Kindly subscribe to this channel and like more videos in this channel so that we are in position to support a number of medical people out there that could be struggling with understanding some of these concepts. So I'm glad to take you through today another condition that affects the respiratory system, and that is majorly the obstructive pulmonary disease. We have very many conditions that are under chronic obstructive pulmonary disease because it's like the umbrella or a specific type of condition. So we have bronchial asthma belongs to this specific condition called pulmonary uh, obstructive disease or chronic obstructive pulmonary disease. We also have what we call bronchiolitis, can be a chronic bronchiolitis, inflammation of the bronchioles. We can also have what we call emphysema. Emphysema is also another condition that affects the respiratory system. Yeah. So we need to define what it is. So we see that the chronic obstructive pulmonary disease is that disease that is characterized by airflow limitation, like limitation in the airflow. It can be in or out. Okay, so when there is limitation, when there is obstruction, when there is an effect, we call that specific condition, or we call that specific phenomena chronic obstructive pulmonary disease. That's why at the beginning I say that even asthma belongs to it because of this property. So what are facts about the obstructive pulmonary disease? We see that cigarette smoking can be a cause for it. And then when we look at its epidemiology, we see that according to World Health Organization, it estimates 1.1 billion smokers worldwide to have been predisposed to this specific condition as a result of smoking. Then this is still under epidemiology. We see that the mortality rate worldwide is being illustrated here. So in your free time, you can have a look at this. We see that mortality rate not only for COPDs but also other conditions like diarrhea, ischemic heart disease, cerebrovascular disease, and then the lower respiratory infections. What are the risk factors for chronic obstructive pulmonary disease? We see that the host factors sometimes can be the genes. Then we have hyper responsiveness of your patient. Then we shall also have lung growth. Okay, tobacco smoke can expose somebody to this condition, occupational dust and chemicals. So we see that some of our industries, or most of people work in the industries whereby we are always exposed to dust. Maybe building, you're always opening the cement bags, and in the process there is dust and you're inhaling these different dust and chemicals. Not only that, there are also other construction works that could expose somebody to it. You could also be maybe doing any other work that you can think of being something that harbors dust. Yeah. Then infections can also be a problem, and then socioeconomic status can also affect us. So what are what's the pathogenesis of chronic obstructive pulmonary disease? Yeah. So we know that it is noxious agents, like there should be something that triggers it. And some of the things that we have just covered before or in the previous slide, we see that there is tobacco smoke, pollutants, occupational agents can bring about that. So we want to see how does this come about. we see that the noxious particles and gases, you find that it brings about inflammation of the lungs. If you've not watched a video in this channel concerning asthma, it clearly explains to us how inflammation comes about when we get exposed to allergens. Yeah, I request that you spare your time and watch that video before you watch this one, so that you connect from one lecture to the other, not getting surprised of the terms that we may be talking about. Then we have these are like how this comes about. We see that if lung inflammation has taken place, it can lead us to chronic obstructive pulmonary disease, whereby there is inflammation of the bronchioles, you can have inflammation of the trachea, you can have inflammation of the bronchi. So all that can bring about that. So there are things that would promote or trigger or bring about this inflammation or chronic obstructive pulmonary disease pathology. You see that there are proteinases. So in case you want to manage the condition, you are looking at giving the anti-proteinases, because if you do that, you are going to inhibit progression of this condition to obstruct or to be a chronic obstructive pulmonary disease. You can also look at the oxidative stress as another factor. So you can look at giving antioxidants, which will help to inhibit the oxidative step. And if the oxidative step is prevented, you are able to prevent chronic obstructive pulmonary pathology from continuing. So when we see that inflammation, we see that the small airway disease is what our chronic obstructive pulmonary disease is. We know that our airway has very many parts, where we have the trachea, we have the bronchi, bronchioles, we have alveoli sac, alveoli duct. So the small airway disease can be airway inflammation, or it can be airway remodeling. So you find that an inflammation can take place, or the tissues will try to remodel. And one of the way it tries to remodel is by secretion of excess mucus, because it is sensing there is a problem at a specific site. Parenchymal destruction, whereby we see that there will be loss of alveoli attachment and decrease of elastic recoil. If we have decrease of elastic recoil, we know that our airway has a problem, and there will be limitation in inspiration and expiration. So when you look at asthma and chronic obstructive disease, we see that the sensitizing agent, uh, we looked at these cells, the CD4 cells, the T lymphocyte cells, and then the eosinophils. This is a type of white blood cell. We know that white blood cells are divided into those ones that have granules and those that do not have granules, the granulated and the non-granulated. So when you look at the granulated ones, we have the eosinophils, we have the neutrophils, and then we have others. Then the non-granulated ones is when now we have the different other types. Yeah. So this is also explaining, the specific slide is taking us through how this comes about. Okay. Then what are some of the causes of airway or airflow limitations? What are some of the things that bring about airflow? We can have irreversible airflow limitation. It can be as a result of fibrosis and narrowing of the airway. It can be as a result of loss of elastic recall due to alveoli destruction. When the alveoli are destructed, we know that alveoli have a surfactant in them, and that surfactant enables in management of surface area around the alveoli. So when maybe we have a decreased surfactant, even the action of the alveoli is going to reduce, and once that reduces, we shall have issues with the alveoli recoil. Yeah. Then it may be as a result of pulmonary embolism or pulmonary edema, can also have issues and affect the alveoli from recoiling. We also have what we call destruction of alveoli support that maintain the patterns of the small airways. When that happens, we can see that it can affect. So what are some of the four components of chronic obstructive pulmonary disease management? You need to assess and monitor the condition, reduce risk factor. If you have identified the risk factor, because you need to identify by asking your patient, maybe when does it start, how did it start, where did it start, was it when are they smoking? In case a patient is smoking, you need to stop the smoke, or you encourage them to stop smoking. Yeah. Then manage stable COPD. You can manage them through educating the patient, carrying out health education talks, sensitize the community about this specific condition. And then you can also use the pharmacological management and then the non-pharmacological management of this specific condition. And then you have to manage the condition from like excavating, like becoming big or much, or like like the stage increasing. So you need to apply that. So what are some of the objectives? Why would we bother to manage this condition? We need to always be having objectives when we are managing every condition of a patient that we are handling. We see that we need to prevent the disease progression. We need to prevent this disease from continuing. That's why we said in the last point in the previous slide, we said that we are preventing exacerbation of the condition. Then we need to relieve symptoms. If you have identified the symptoms the patient is suffering from, the patient is having difficulty breathing, the patient is having cyanosis, kindly check on your patient and manage the symptoms. Okay. Improve exercise tolerance. We said when we looked at asthma in the previous lecture, we said that exercise can be some of the triggers for asthmatic attacks or asthmatic condition, or can be a risk factor. So you need to improve exercise tolerance, because if you give the medication, meaning the patient will be in position to do exercise at ease or without any I can say without any inconveniences. Yeah. Improve health status. Improve the health status of your patient. Then prevent and treat exacerbations, like we have just discussed briefly. Then prevent and treat complications. You should be in position to prevent and treat the complications, reduce mortality, and then minimize the side effects from treatment. So how can we diagnose? We see that some of the symptoms that your patient is going to present with cough, sputum, and then dyspnea, shortness of breath. Okay. Exposure to risk factors. Some of the things that expose: occupational, indoor or outdoor pollution. We also have tobacco. So you are going to use this specific machine that we call the spirometer to be in position to diagnose your patient. But as you're taking history, you inquire more about how they are breathing, what time does the thing affect, what type of work do they smoke. Yeah, you have to ask the patient all those things. So what are some of the factors determining severity of the chronic obstructive pulmonary disease? So severity of symptoms: if you are not managing the symptoms, the symptoms are going to get severe. Severity of airflow limitations: we saw what are the things that bring about airflow limitation. Frequency and severity of exacerbation, presence of complication of the chronic obstructive pulmonary disease, presence of respiratory insufficiency, comorbidity, and then the general health status. Number of medications needed to manage this specific disease. How do we classify the severity of the condition? We classify the severity as mild, moderate, severe and very severe. And this is after we have gotten readings from our spirometer. So we shall be in position to classify them. So these are some of the ranges. You can pause this slide to appreciate the different ranges. So for that will enable us classify it as severe, moderate, and mild. Management of chronic obstructive pulmonary disease, we see that avoidance of risk factors. If you want to manage, avoid the risk factor. If the risk factor is smoking, stop the patient from smoking. If the risk factor is occupational, maybe pollution, indoor or outdoor, try to encourage the patient to reduce maybe the nature of the work, or maybe the company should allocate them to do another duty that will not expose them directly to pollution. So you find by doing so, you are helping your patient. Then you can also look at the influenza vaccination of your patient. So what is stage 1 management? How do we manage? You look at the characteristics. You need the patient will present with cough. The patient will present with sputum. So you may not need a spirometer, or there may not be any abnormalities when you are taking readings from your spirometer. Then what about mild chronic obstructive pulmonary disease? We already saw the different values that we would get. And then what would the treatment be? We have the short-acting bronchodilators as needed. So when we look at bronchodilators, since there is constriction, we are focusing on how do we dilate. And some of the drugs that we use for dilation are beta agonists. And examples of beta agonists, we have the salbutamol, salmeterol, formoterol. Those are some of the drugs. And we know that once we give them to the patients, they are going to bind to the receptors and they enable the neurotransmitter to bind. So when the neurotransmitter binds, it brings about dilation of the bronchi instead of constriction of what? The bronchi. Then we have the moderate COPD. This is how you range them. So we look at, these are their values here. This other side, we see that these are the different values that you can read from the spirometer for you to gauge that it is now moderate. What is the treatment? We also use the short-acting bronchodilators and then the long-acting bronchodilators, and we shall also need rehabilitation of this patient. Then when we look at stage 3, we still need the short acting. I would love to refer you to the previous lecture on bronchial asthma because we digested the mechanism of action of these drugs. Here we are just mentioning them. We are mentioning the classes. In the previous lecture, we have also listed the different examples of different classes, what are their side effects, and what could be their adverse drug reactions. So I would love to refer you to the other side. Please kindly watch management of asthma before you come and watch management of chronic obstructive pulmonary disease. Yeah. So stage 4, we can see still the drugs are remaining the same, and sometimes you may need to do the surgical options. So this is just what we have looked at and how you would manage. In your free time, you can pause this slide and you go through it so that you are able to appreciate. So you need to ask the specific questions when your patient comes in. You can ask, do you know what COPD is? And then, do you cough several times most days? Do you bring up mucus most days? Like, these are questions you need to ask. How old are you? When did it start? Do you smoke? Have you been smoking? Have you smoked in your life? Are you an ex-smoker? So thank you so much everyone for staying tuned up to this time. That marks the end of our lecture under chronic obstructive pulmonary disease. Today we are going to handle what we call cough as another class. So I would love to stop here for the chronic obstructive pulmonary disease. In the next few minutes, we shall be handling cough. So please don't go any far because cough is more interesting, just like how others have been interesting.